All right, well, thank you all for joining me today for this RATS Learning Lab. Today we have Dr. Kasi presenting on liquid biopsies and circulating tumor DNA. So with that being said, I will go ahead and hand over the presentation to Dr. Kasi, and we'll get started.
Just going to maximize the screen. So you can see my presentation?
Yes.
So my name is Pashtoom M. I'm one of the assistant professors at the College of Medicine and Oncology here at Mayo Clinic, Florida. I trained in University of Pittsburgh and then moved to Mayo Clinic in Minnesota, and then I'm heading the GI oncology program here and focusing mainly on colorectal cancers. And outside of colorectal cancers, I have a focus on individualized medicine or precision medicine, and within those big umbrellas, liquid biopsies, and also we'll touch briefly upon pharmacogenomic testing kind of ways of how we're utilizing it in real time in patients with colorectal cancer and some of the other GI cancers, and I'll share some of the real experiences. Feel free to interrupt as we go on the slide as well. I could take questions at the end, but during as well, because some of these slides may or may not be as clear as, so you can ask the question right there, and then we should have plenty of time for questions and discussion. I would look forward to that. And my email and my Twitter handle is also there, so please feel free to email or discuss. I'd be happy to follow up on questions later as well. And I briefly mentioned before as well, if you guys were looking to come to Mayo Clinic, Florida, we're happy to show you our lab and some of the work that we do here. These are my relevant disclosures. A lot of it is research support that goes to the institution, not to me. And we'll talk about off-label use of liquid biopsies or circulating tumor DNA, and briefly touch upon pharmacogenomic testing as well. So my three main learning objectives are: I wanted to show the results of the feasibility as well as the value of applying liquid biopsy or circulating tumor DNA testing in real time. I wanted to show how feasible and valuable it is to do pharmacogenomic testing, and I'll touch upon some of the available liquid biopsy platforms that are available commercially and also in the area of research. So to give you an idea and a primer as to what options you have and what are the strengths and weaknesses of each. Before I go into liquid biopsies for colorectal cancer, one area of research interest that is particularly of interest to me is how these tumors evolve, and that's where the liquid biopsies also come into play. I want to kind of share in a case that we had during my fellowship in training, and this is a patient who actually had leukemia, and what you see on the y-axis is bone marrow blasts, which are these cancers that are visible in the bone marrow, and also the blasts can also be present in the blood. They're essentially cancer cells, and things going down obviously means that the blasts or the cancer cells are decreasing in number and quantity, and things going up obviously means that the cancer is worsening. So this patient was started on this regimen, which is called 7+3. They get 7 days of one chemo, and then they get 3 days of another chemo. And we only cure patients with leukemia if they get a bone marrow transplant. So this patient ended up getting a transplant around May of 2014. But then the problem was right thereafter, within 30 to 60 days, there was recurrence of his leukemia, and things were worsening. At the time, there was one target or mutations that we could target for this particular patient's case. He had something called a FLT3 mutation, and around that time in August, September at Mayo Clinic, we had a trial that specifically targeted that mutation, a FLT3 inhibitor, so to speak, this ASP2215. So he was put on that study, and he was cruising along well. And again, a lot of these targeted therapies don't necessarily cure the cancers, but they can control it really well. And as you can imagine, in somebody's leukemia not getting better after fully aggressive chemotherapy and a transplant, you can imagine the fact that you can even achieve control. That's a very good endpoint. This is his story. It was published in the Wall Street Journal in March of 2016, and I can share the link later. But if you Google the cancer treatments new direction, kind of shows a little bit of background as to why we do what we do. This is his older brother that gave the bone marrow at the time. Unfortunately, it was recurrence right thereafter. But he was able to improve along well. But then what started happening was, so as you can see, he gained weight, and target treatments, they're more tolerable than chemotherapy, so he was doing well. But unfortunately, what started happening was all of a sudden his leukemia started getting worse. And what was really interesting was that so the tumor did have the same FLT3 mutation that we were targeting, but it actually acquired the famous Philadelphia chromosome, the translocation 922, for which we have that magic drug called Gleevec. So that was the mechanism of resistance. Simplistically speaking, we block these highways that the cancers take to grow, but then they start forming streets around it. And here we were seeing it happen in real time. Fortunately, this Philadelphia chromosome, there are multiple drugs that we can use. So we discussed this case at our molecular tumor board and also some of our experts. So we ended up choosing a drug that not only attacked FLT3, but also targeted the Philadelphia chromosome, and we were able to get him to a second transplant, and this was April of 2015, and now we're in April of 2018. The patient is cured and is disease-free still, but kind of is a really real life, real example of a case of a tumor undergoing, clonal evolution, like Darwin's survival of the fittest, or evolution happening in real time. And that's something that really fascinated me from a research standpoint, and really had an impact in terms of some of the research stuff that I've been focusing on. I don't need to tell this audience that more young people are dying of colorectal cancer. This is something that was a focus of a lot of research publications last year, where they noticed a rising trend in individuals in their 20s, 30s, or 40s who otherwise wouldn't necessarily be screened with a colonoscopy, but are unfortunately getting diagnosed with colorectal cancer. And as you can imagine, because they get diagnosed with imaging studies, they're often advanced at the time of diagnosis. On the right hand side is a picture of one of our patients who was diagnosed at the age of 20. She just passed away a couple of months ago at the age of 26. So, for 6 years she battled the stage 4 diagnosis of colorectal cancer. And even though with all the different drugs and treatments, she lived for 6 years, but somebody at the age of 20 dying at 26 is still not something that is a successful target per se, or unless we can cure these cancers. So this is an alarming trend. This is our own Mayo internal data, which we've written the manuscript and we'll send it for publication. But in general, it recapitulates some of the findings that have already been presented. We'll be presenting this at ASCO this year as well. What you see as a common trend is, because of colonoscopies, you see a decline in individuals in their 60s or 70s who are diagnosed with colorectal cancer, but you see this upswing in individuals who are 20s, 30s, and 40s. And this is just one time point. You see that the colorectal cancers are increasing. Now, that being said, we now have more tools in our toolbox, which on the left-hand side include chemotherapies, some of the biologic agents like anti-EGFR, cetuximab, panitumumab, and then anti-VEGF like Avastin, which stop the growth of blood vessels. And then you have TAS-102 or Lonsurf or regorafenib as some of the targeted therapies that are now approved after having failed chemotherapies. And then with the mutations, we're getting new drugs like BRAF inhibitors and MEK inhibitors, which are some of which are showing very promising results in trials. And I wanted to take an example of BRAF mutant colorectal cancer, which is the more aggressive variety of colorectal cancer. And as an example, here, as you can see, it's not just one wonder drug that has helped improve the survival of these patients. It's that we have multiple drugs that can be used one after the other after the other. And this slide is a decade old. So this slide is from 2008. We're into 2018. So with every new agent that came along, as you can see, the overall survival has been being pushed to the right. So the curve keeps going to the right, which is good. On average, even if you have metastatic cancer that does not make it to any surgery, you're looking at least not the average, but a median of 3 years. And with some of these young patients, you're looking more on the right-hand side of the curve, where people are living in the order of more than 3, 4, 5 years, just like that other patient of ours who unfortunately passed away recently. These cancers take multiple highways to grow, and for colorectal cancer, the RAS, RAF, MEK, ERK highway is important. And for patients with BRAF mutant colorectal cancer, that switch is turned on, so the cancer continues to grow. What is really fascinating is like right now we have a trial that does not even have any chemotherapy. So what they've noticed is that not all mutations are created equal. So for example, this drug, which is called encorafenib, which blocks the BRAF mutation, it works really well for melanoma, but it doesn't work at all for colorectal cancer. But what they found was if you did a double blockade of the BRAF, and then in the orange, if you block the MEK, and then in the green, you also block the first step, which is the EGFR, then the results are very promising. This was presented last year at the European Society for Medical Oncology in Spain. These were the preliminary results of 28 patients who had received, multiple chemotherapies and were getting this combo. Things hanging down on this waterfall plot means that their cancer shrunk. So this is very encouraging. Most of the times these patients with BRAF mutant colorectal cancer, they don't respond to chemotherapies and they fail pretty quickly. And the arrows here indicate that the patients where they did respond, they continue to be on this regimen, so the responses are durable. Now the problem is these tumors are not just one blob of cells that are identical to each other. They are more heterogeneous. More and more some of these new books and diagrams that show colorectal cancers or any other cancers, they're not just using one color. So it's a population of cells, and depending on where you're getting a biopsy from, the actual tissue, you may be missing the whole picture. It's just like having children. Even if they came from the same parent, and even if they were identical twins, if they grow up in different families altogether, they may develop completely different personalities and may behave differently. So to assume that all the cancer in the same patient is going to behave alike is no longer the case. This is real patient results of the liquid biopsies. Every color represents a mutation. All of these patients have BRAF mutant colorectal cancer, but as you can see, the results are so different from each other. So to assume that all of these patients will behave the same way to the same drugs is not necessarily true per se. Again, simplistically showing that a lot of times problem is it's not that the treatments don't work, it's just that they evolve with time. There might be cells that are already resistant to begin with, or just in the example that I shared earlier from the leukemia patient, you can acquire mechanisms of resistance. So these cancer cells are smart, they know what you're blocking, and then they can figure out streets around it. So in terms of liquid biopsies, the concept is a lot of this was already present and being done in the world of obstetrics and gynecology. So as you might have heard, individuals who are pregnant can get a simple blood test to kind of know what the sex of the unborn child is going to be. That's because the fetus or the unborn child is foreign to the mother, and as it's growing, it sheds DNA into the bloodstream, and that can be captured now with these more sensitive tests and able to differentiate between which DNA is coming from the fetus and which DNA is coming from the mom. So with bioinformatics and some of these technologies, they're able to pick those up and tell, for example, the sex of the unborn child, or for example, they can screen for if the fetus is going to have Down syndrome or some of the other syndromes that can be captured on a genetic basis level. Same concept goes for tumor as well, because the tumor, as you can imagine, even though it arose from the same person, it is a foreign organism, and as it's shedding its DNA into the bloodstream, that can be captured in a non-invasive way. Some of these test results are back within a week's time, and then you can also, if you did serial biopsies or serial liquid biopsies, the reason why they call it liquid biopsies is because we're not getting an actual biopsy of the tumor, we're just doing a simple blood test. So the term liquid biopsy is somewhat misleading. We are getting, in fact, a picture or a snapshot of the actual tumor, but it's just a simple blood test. My initial experience with this was more serendipitous because I was seeing a lot of patients where their initial biopsy was not performed at Mayo Clinic. We get patients from across the country and from across the world. So a lot of times their biopsy was not done here. They were diagnosed somewhere else, and now they come to us for clinical trials and for seeking options once they've already failed the traditional available treatment options. So one problem was that I didn't have that biopsy sample. So it will take us, for example, weeks to get the biopsy. We'll have the patient sign a release. Then my assistants will try to figure out where they got the biopsy done and request the original blocks to be sent over. And then the most frustrating part was after 4 to 6 weeks of actually getting the specimen and then sending it out for testing, the worst outcome is that 2 months later, you could come back with a result where they say, well, the tumor wasn't enough, we need another biopsy. So you've lost like 2 to 3 precious months in terms of getting the biopsy. And then, kind of begs the same question, is this tumor that the person has now that has seen so many different kinds of chemotherapies or targeted therapies, the same tumor which the patient started off with 2 to 3 years ago? More and more research is showing that that's not the case. The tumors evolve with time, especially if they are treated. You cannot be right in assuming that this is going to be the same tumor. So that's where I started doing some of these liquid biopsies where I didn't have access to tissue or the biopsy was not possible because of safety reasons, or if the patient did not want to get another biopsy. So I was in a situation where I needed the mutational information and to see if there are mechanisms of resistance or to find the right clinical trial for the patient, but I didn't have access to the actual tissue. So I started doing these liquid biopsies, and that's where I started learning as to what are the pitfalls and drawbacks, and also what are the strengths of this process. This cartoon also depicts, simplistically speaking, that these cancers are not just one blob of one color cells. They are a population that obviously arose from one parent, but clearly there are clones or subclones that are present that give it heterogeneity. So, let alone comparing cancers between individuals, even within the same individual, the cancer may not be the same. There are multiple trials, more on a research basis, that have shown that that's the case. But now with this non-invasive test, we as GI oncologists who treat colorectal cancer have the opportunity of studying this in real time. So again, the bottom panel depicts the same issue that a lot of times, when we start patients on chemotherapies, their cancers shrink. But then, 2, 4, 6, 8 months later, the cancer starts growing again. So what happened? What happened? It's the same chemo, same doses. Why is the cancer not working, the treatment working anymore for the same cancer? And the reason, because there are now resistant clones that probably were there to begin with, or these cancer cells, just like I said earlier, are smart and they figured out ways of getting around the treatment. And we'll show some of the results of some of this that we did in real time. Just because my institution was already doing Garden 360, that's one of the commercially available platforms. The other one, Foundation One, that does the tumor testing, also has a Foundation Act panel that also is liquid biopsy. There are many vendors now coming forward. Every time I go to ASCO or ASCO GI, there's another company who is trying to come with their version of the liquid biopsy. So it is one of the more interesting areas that are expanding, and it's good actually that we're having more competition and different tests. But at this point in time, I would say that all the available tests are relatively similar. One may claim over the other that their test is more sensitive for a particular aspect. It all depends on what kind of tumor and what question are you asking. So for me, as focusing on colorectal cancer, this particular panel gives me the RAS, the RAF, the pathway that I showed you earlier. It also tells me a little bit about if they have some of the genes or MET amplifications that may be mechanisms of resistance. And so it pretty much covers the most of the mutations that I need to know from a colorectal cancer standpoint. Plus, it gives you other mutations as well that are good to know. So it kind of was serving the need that from a colorectal cancer standpoint. So that's the test that I've been using. Last year, between me and one of my other colleagues in GI, we've done more than 600 liquid biopsies. So, those are all on real patients. This is one of the first patients that I did a liquid biopsy on back in 2016. This is, again, a young patient, 38-year-old at the time, was diagnosed with colorectal cancer at the age of 35. Pretty much got all the chemotherapies. At Memorial Sloan Kettering, they also do like a pump in the liver where it continuously keeps giving chemotherapy in the liver. And as you can see, some of these white circles are calcified or calcium deposited cancer that, as it dies, it just calcifies because of the chemo that's going through it. But on the darker end, you see this dark shadows. Those are the cancer that was coming back. So this was a patient who, by the books, had failed all these chemotherapies. You see the lines of therapy. He got oxaliplatin, the 5-fluorouracil or the pump that you go home with. the irinotecan chemotherapy. Some of the chemotherapy also got recycled. Then he also got cetuximab, which is an anti-EGFR agent. So pretty much, and at this point in time, didn't want to do anything further, and didn't want to get another biopsy. So I did a liquid biopsy, and on the left panel, you see the results of his liquid biopsy. So, that was very surprising. The percentage here shows that how much of the blood is actually tumor DNA. So, if you're getting somebody's blood drawn, most, if not all of it, should be the person's own DNA. It should not be tumor DNA. And the first time I got a result initially was somebody who had a circulating tumor DNA, which it said 5%. And I was like, well, 5%, is that a lot? Is it less? 5% doesn't sound like a big number. But if you think about it, in somebody's blood, if 5% of that is coming from the tumor, that's a lot of DNA. And in talking to the company and their scientific committee, and to kind of get a sense of what these results mean, on average, most of their results are 0.2%. So anything detectable technically is relevant, and on average, anything above 0.2% is a lot of DNA per se. So you can imagine that 54% of somebody's blood with DNA coming from the tumor is a lot of DNA. And we had the results of his baseline genetic testing from his initial surgery from years ago. And that only showed the first two mutations, which are colored in blue, which are the usual suspects, the TP53 or the APC that makes colon cancer what colon cancer is. And he was what we call RAS-RAF wild type, meaning there were no mutations present in the RAS or the RAF. But then you see all these different colors that are showing different mutations. These were all mechanisms of resistance that the patient's tumor acquired that were not present at baseline, but now would help explain why the cetuximab that was working so well stopped working. So this is a follow-up. So we were able to radiate the liver metastases, and then we were just watching. Later on in May, the cancer started coming back now in the lungs. But then when we did the liquid biopsy again, all those colors which represented all these different mutations were not present anymore. So, we had grounds to maybe give him the exact same treatment that failed in October 2016 again in July. And it worked. The same chemo and the cetuximab, the exact same drugs that had stopped working in October 2016, which by the books is already something that is checked off, so you can't really use it again. And you can't really make the grounds. Now, a lot of times in the world of oncology, if some cancer drugs have not been used for 6 months or so, we can always recycle. But as you can imagine, the hopes of things working when you're kind of just recycling failed treatments is not that high. And especially if somebody had side effects to the previous treatment, they're not too enthused about trying something that may or may not even work, but for sure will make them sick. So here we had grounds to try exactly the same drugs that had failed before, but it worked for the patient. Now, again, did we cure him? No. But did we, increase the quantity as well as the quality of his life? He was having a lot of symptoms from, so we chose the right drugs, and we were able to, by the books, he would have been hospice in 2016, but we were able to give him all this treatment and give it in the least amount of drugs that would be the most effective for him. So I would argue for sure, I don't have a trial to show, and I think that would be nice to do, where you can show and do liquid biopsies and show if that improves survival. But I wouldn't be surprised if that truly is the case. Again, yet another example of a patient with BRAF mutant colorectal cancer. We had this patient on immune therapy, and again, you see those some clones disappear and some clones persisted. So again, to assume that the cancer remains the same after you do treatment is not true. And here, these are not just cartoons; these are real patients, real treatments. So you see these tumors are evolving and changing, and to assume that they're the same as they started off with liquid biopsies, we can non-invasively. Now, I can't imagine this person consenting for 4 biopsies just because we wanted to see if it's changing or not, but a blood test is very reasonable. This is yet another example. The red here indicates ERBB2, which is HER2. About 4% of colorectal cancers acquire HER2 as a mechanism of resistance. So 4%, even though it appears a small number, but you guys know how common colorectal cancer is. And if I'm seeing 100 patients a month, and if 4 of them have HER2 as a mutation or amplification as a target, that is very valuable, and there are drugs that are very effective in targeting the HER2 pathway. Now here, as you know, Herceptin is a drug, or trastuzumab is a drug that's approved for breast cancer and also stomach and esophagus cancer, but it's not approved for colorectal cancer yet. There are several trials that are looking into getting drugs that attack the HER2 pathway. Here we were able to get what we call compassionate use. We were able to request the drug company to provide a drug for compassionate use under no cost. So we were able to get those for the patient and put the patient on anti-HER2 drugs in addition to chemotherapy. And initially it worked, but then it's the marker, the CEA, which is a tumor marker, started going up again. And see how different it is. What was evolving later was not the same that was responding to HER2. So, and this is back in July, and we saw the patient again last month, and then the tumor continues to evolve, and it's so striking that it keeps changing with time. These are additional examples of patients where they were on anti-EGFR therapies that blocked the highway that I showed you earlier. And there are research articles that were showing that at the time when these treatments were failing, these tumors were acquiring RAS mutations or EGFR mutations, or they were acquiring MET amplifications. As you can see, none of the green mutations in the RAS pathway were present at the time, but then with time, it appeared. We were able to actually have the surgeon take out the spots that were growing, so that's why you see that those mutations just now are ND or not detectable anymore. So again, real-time example of a patient having a tumor that did not have any mutations, acquiring mutations as mechanism of resistance, and then us changing our plan for treatment as it was evolving to get the patient the best chance at fighting this. Another example, this light green color that you see is another example of a RAS mutation acquired on treatment. So again, another example where treatment worked initially, the amount of circulating tumor DNA went from 0.6% to 0.2%, but then the cancer started getting worse again. And what was different? Why did it stop working? And as you can see, that light green color is the mutation that the tumor acquired as a mechanism of resistance. It can also be used to keep track of how somebody is doing. As you know, even patients with stage 4 cancer, if they have 1 or 2 spots in the liver or 1 or 2 spots in the lungs, our surgeons, with minimally invasive surgeries, if we start off with chemotherapy first and shrink things down really well, the surgeons are not opposed to doing surgeries. They will do and take out the primary, and a lot of times they take the liver metastases out in the same setting. For the lung, sometimes we have to stagger it, but you can monitor response to treatment over time, and also see if the cancer comes back, or if they have recurrence, you could do a liquid biopsy non-invasively to see if it's back or not, especially if you can't get a biopsy. Yet another example of a patient where initially the anti-EGFR therapy worked really well, but then when the cancer came back, it had acquired the NRAS mutation, again, a mechanism of resistance, and we have obviously stopped that drug. And there's interesting research showing that if you stop the blockade that you placed on that highway, with time, some of these clones may just disappear, just by you taking off the pressure that you had imposed. By taking that pressure off, simplistically speaking, the highway starts opening up again, and those clones may disappear as you take the pressure off, which is very intriguing. This is yet another example showing that these clones that may be present initially may disappear. So to assume it's the same cancer, same color is not necessarily true. And depending on where you're getting the biopsy from, a biopsy from the primary cancer, from a spot in the liver to a spot in the lung, especially if it undergoes treatment and changes, is not necessarily the same tumor anymore. Yet another example of a patient who acquired an NRAS KRAS mutation on treatment, and showing why it wiped out the clones that it was sensitive to, but then the clones that were not sensitive to showed up again. Interestingly, as we know, immunotherapy is like the next big thing. Everybody talks about getting immunotherapy for patients with colorectal cancer, or for that matter, any cancer. As we know, the laundry list of approvals for immunotherapy keeps increasing. Every other month I see an approval for another kind of cancer. For colorectal cancer, as we know, it only works for the mismatch repair deficient, or the microsatellite instability high, or the Lynch syndrome, or the tumor Lynch, or the germline Lynch syndrome patients. They're all synonymous terms which end up in the cancer being hypermutated. These patients who have what we call mismatch repair deficient tumors, what was very intriguing was on average, they have 1,700 mutations, as opposed to only 70 mutations, roughly speaking. If you look at the article that was published in New England Journal that led to the approval of immunotherapy for colorectal cancer, that's why immunotherapy works so well for mismatch repair deficient tumors, because these tumors have so many mutations that they're so deformed and they have so many proteins on their surface and antigens that your body's immune cells or policemen are able to tell the difference between what's enemy and what's not self per se, and they are able to attack it. Whereas for the run-of-the-mill colorectal cancer that is proficient mismatch repair or microsatellite stable, that one does not have a lot of mutations. And this is a paper that I published last year. If it's the number of mutations and the panel is at least detecting 70 of them, on average, you should see more mutations if it's a patient with Lynch syndrome as opposed to a patient who does not have Lynch syndrome. And as you can see, the picture speaks for itself. The patients in the above panel are very different. You don't need mathematical formula to tell you that those tumors which are in the above panel are different than the lower panel. And yet another example that you could pretty much predict maybe the patients who may respond to immunotherapy by doing a liquid biopsy. Again, in summary, this is helpful to keep track of tumors over time to see if the cancer is getting worse, the cancer is getting better, if it's the same, if it's acquiring mutations. Now, in the assays that are available, it's important to know what are you sending the patient's test out for. This is a nice summary where it tells you that most of the assays that I was talking to you about, the Gardner 360 or the Foundation One Act, they are next generation sequencing assays. So they are more comprehensive. They give you information regarding copy number gains. They give you information regarding mutations. As you can imagine, they're a little slower, but the speed is getting fast. Previously I was getting results in 2 weeks. Now I'm getting results back within a week. So I can even change the first treatment as soon as I know if they have a BRAF mutation, or if they don't have a RAS or RAF mutation. I can change their treatment even before their first or second cycle of chemotherapy. As opposed to PCR-based testing, they're quick. They are focused. So a lot of the PCR assays may look at 1 or 2 mutations, and you can track that over time. So different purposes, depending on what clinical question you're asking, the cost, the rapidity, the comprehensiveness is different. This is another test that is not necessarily giving you mutations that are actionable. It's giving you mutations more so to see if you can detect recurrence. This is already available in Australia, and it's commercially orderable, and as opposed to a Gardner 360 or a Foundation One, which is in the order of $5,000 to $6,000. This is $400, but the question it's trying to answer is different. This is helpful to detect recurrence, and some of the posters and papers that were presented at ASCO last year and ASCO GI, they were able to detect recurrence of the colorectal cancer on average, 9 months to a year before the scans showed recurrence. And again, it's a blood test. It's pretty sensitive, as you can see. The bigger the size of the tumor, the higher the stage, the more accurate it can get. So this is undergoing further protocol testing in the United States as well in different trials. Again, as a comparison, when you look at methylated markers like Colvera, the turnaround time is faster, the cost is lower, but then that information is different. That information is only giving you, is the cancer back, yes or no? So different question, different implications. Whereas mutation analysis, which is next generation sequencing based, is obviously more expensive. And in the future, I don't think that one is going to be the answer. You may want to do, let's say, a methylated marker to kind of keep track of cancer over time. And whenever it's getting worse, that's maybe a time where you may want to do a more comprehensive sequencing, just as a thought. This was a poster that was presented at ASCO GI last year. This was results of liquid biopsy testing in close to 1,400 patients, and they were able to show that they were able to detect circulating tumor DNA in most of the patients with stage 3 and 4 disease. And a lot of these results, which are shown in red, were very consistent with previous studies that are TCGA based, or the Nurses Health Survey based studies, that they were showing similar numbers of mutations. So whatever results you're getting, they are reliable, because a lot of these mutations are mutations that are known of value, like KRAS, P53, BRAF, APC, and you have to kind of know if it's clonal versus subclonal to kind of know if it's important or not. And they were finding new targets and new mechanisms of resistance as well. They found these two mutations, for example, that were making cetuximab and panitumumab not bind to the active site. So in 3D, these drugs are binding to receptors, and with this mutation, it was making the tumor, not the tumor, it was making the anti-EGFR drug not bind to the receptor, and that's why the drug was not working. So you can pick up these mechanisms of resistance, and in their study too, just like the examples I showed you, in 84 patients who had serial monitoring, and I personally have had now at least more than 40 or 50 patients where I've done serial monitoring, they had either a gain or loss of clones over time, just like some of the other examples that I showed you. So again, to assume that this is the same cancer is not true. And also to assume that, simplistically speaking, that all the cancers on the left will get chemotherapy doublet with VEGF, and the cancers on the right are going to get whatever treatment. These buckets of patients are so different from each other. And the liquid biopsy is truly showing you the heterogeneity, not just in one point in time, but also over time, which is which I think is the strength of this assay. It has its limitations, but I think you need to understand the strength. And it's not meant for all cancers, but a lot of the GI cancers, particularly colorectal cancers, they do shed a lot of DNA in the blood. And you have to do the test when the person's cancer is either not treated yet or worsening, because if it's responding, then you'll get a report that says not detectable, but that does not mean that the cancer is not there. It's just that they didn't detect it in the blood because the amount of shrinkage was less. One thing to keep in mind is something called CHIP, or a clonal hematopoiesis of indeterminate potential. What it means is there are patients, or just not patients, individuals in their 50s, 60s, or 70s. With time, they acquire mutations in their blood cells, P53, JAK2, a couple of other mutations that should only be seen in patients with leukemia. But they did this study where they found these mutations, and as you can see, with every passing decade of life after the age of 50, the presence of mutations that were captured on a blood test was increasing. Now, we don't know, will these patients develop leukemia in 10 years' time, or what's going on and why are they having these mutations? But you could be misled where if you just did somebody's blood test and they're 80 and you found a mutation that was not necessarily specific for colorectal cancer, you may assume that their colorectal cancer is back, but that may just be just their age. So this clonal hematopoiesis of indeterminate potential has to be kept in mind when you see mutations that don't add up, and you have to kind of keep in mind that what age population are you dealing with. Otherwise, you may end up pulling the wrong trigger for treatment. So something to keep in mind. I'll briefly touch, a little bit about pharmacogenomics for colorectal cancer, because that is one thing that we have two approved genes for which we know we can find out which genes are causing them to metabolize chemotherapy. This is an example of one of my patients who developed a severe 5-fluorouracil toxicity because she lacked a gene that metabolizes the 5-fluorouracil, or the pump chemotherapy they go home with. And the antidote, we were able to give the antidote, and that reversed the problems. But the antidote costs anywhere between $72,000 to $78,000, and that patient, we were estimating the cost of the hospitalization that was close to $180,000. To why we should do DPD gene testing for the 5-fluorouracil, or the UGT1A1 testing for the TCAN chemotherapy. And we've been doing this 1-ohm test, which is a company that does comprehensive pharmacogenomic testing on 23 genes. And as you can see, as a snapshot example, it doesn't only tell you about the chemo drugs, it tells you about what blood pressure medications will work best for this patient, or which psychiatry medications are not a great choice for this patient. And we've been using this, it's just a cheek swab. So we've been using this drug, this testing, not just for determining what chemo to give them, but also what pre-medications, in terms of what nausea medications are a great idea, what antidepressants are going to be most helpful, and which will not work for this patient. And it's something that we are incorporating and including into the chart. So I just had a patient last week, 23-year-old, had UGT1A1 homozygosity. I gave him 50% less dose. So you can imagine that that's where you hear all these horror stories where somebody's like, well, my so-and-so got treatment and they were miserable and they were puking their guts out, I'm not going to get chemotherapy. It's not like they got the wrong chemotherapy. It's just that from a pharmacogenomic standpoint, they probably lacked the gene that metabolizes the drug. So that's why they ended up having these toxicities. And we presented this data at ASCO GI this year, and in 2/3 of the patient, they either had the DPD or the UGT1A1 gene, some abnormality. And that's a lot of patients. That basically means even if you're tweaking about 25% of somebody's chemotherapy, you could potentially prevent an ER admission or just improve the quality of life of these patients. And we're trying to do that as a segue. And in the lab, I was telling Risa earlier as well, we're trying to grow these tumors in the lab as well in mice and also in petri dishes to kind of know not just over time as to how this tumor is evolving, but in human beings, as you can imagine, you can only expose them to so many drugs, and it would be nice to know already in the lab which drugs are the best for this particular patient and bring it back to the patient. So kind of doing biobanking and tissue testing as well as blood testing serially and doing experiments at the same site. So it's kind of my role right now at Mayo Florida is kind of an interplay between being in the clinic, seeing these patients real time, doing the liquid biopsies serially, but at the same time, when they initially get diagnosed with colorectal cancer, we try to get an additional biopsy so we can grow them in the lab. And right now we have a drug panel with more than 1,100 drugs that we are trying to screen patients with colorectal cancer that are growing in the lab all at once. So you could, potentially pick the right drugs even way before you even give these patients the treatment. So in summary, I showed you the feasibility and value of liquid biopsies or circulating tumor DNA testing in patients with GI cancers. Briefly touched upon pharmacogenomics, and the cost of some of the pharmacogenomic testing is only $250 or $350, as opposed to some of these over-the-counter genetic testing that is now available, like 23andMe and some of these others that tell you which race you belong to. If there's a test that can tell you about 23 genes, interestingly, it also tells you if you'll metabolize caffeine well or not, as some people, are more sensitive to coffee than others. So it kind of gives you not just information about chemotherapy, but also the supportive care drugs. And then just wanted to give you a snapshot that there are many testing platforms, and there are strengths and limitations of each, which not only include the cost, but also the comprehensiveness. Just wanted to acknowledge the patients and also, our mentors, because all this information that I've received is either through patient experience or, kind of working with my mentors. With that, I'll be happy to take questions or comments, and my email and Twitter handle is there for ongoing discussions, and would happy to continue this even after this meeting.
Awesome. Thank you, Dr. Kasi. That was very informative. I did have a few questions for you, and I just wanted to reiterate that if any of you on the phone have questions, you can either, I believe you should be able to unmute yourself and ask, or if that doesn't work, you can type your questions in the chat box. But one of the questions I had, and it's more of a clarification question, you had mentioned earlier that once a tumor is treated with chemotherapy, it no longer becomes the same tumor. So is there any way to mitigate that, or is there any way to take that into account if, for example, someone has a liquid biopsy done after they've received a first-line treatment?
So, in terms of mitigating the heterogeneity, more and more, I think where the future is headed, it's not going to be one wonder drug. It's likely, as you can see with some of the trials for BRAF mutant colorectal cancer as well, it's not just one drug, and the way to mitigate the heterogeneity is to attack the cancer in multiple ways. So you not only block one highway, but any mechanisms of resistance that the tumor may acquire. So these tumors are not simplistically taking one highway to grow. There are some cancers where one pill works great, and that's because the cancers are just using that particular highway. Colorectal cancer and a lot of the GI malignancies, they have a complex circuitry and a network of highways that they take to grow. And there was a great talk at ASCO about that heterogeneity is not necessarily just seen with targeted therapies, because targeted therapies, as you can imagine, they're more specific. They block one particular highway, as opposed to chemotherapy, which is a little bit more diffuse and generic. But heterogeneity results from all treatments. So pretty much any treatment does cause heterogeneity. So I don't think there's a way to overcome that other than being smart about doing combination treatments, where if one drug was wiping out one clone, the other one you would hope that wipes out the other.
Right. Well, thank you. That makes sense. And then my other question had to do with so I believe it was last month, or yeah, I believe it was March. Both CAP and ASCO came out with a review discussing how liquid biopsies may not be ready for prime time yet outside of clinical trials. I was curious what your take on that was, and if this is like what other factors have to be considered before really saying that liquid biopsies are ready for prime time.
It's. I'm glad you brought it up, but because the thing is, there was before that those guidelines came out, there was also another paper in JAMA Oncology where they said pretty much the conclusion was liquid biopsy not ready for prime time, and if you look at the actual paper, it wasn't even a full paper; it was a research letter. And if you look at the methodology, they only focused on patients with prostate cancer, and what they did was they sent the blood tests from the same patient at the same time to two different laboratories, and they compared the results crudely, and they said, well, no two results were alike, so this is something that we shouldn't be doing. And maybe that's true, maybe, but then the conclusion should be, well, that's not ready for prime time in prostate cancer. But then all of a sudden, this whole stream of debate was not ready for prime time at all. The other thing is, my experience has been serendipitous because of the need where I needed to do liquid biopsies because I didn't have the tissue. A lot of it, we've learned a lot in terms of, I myself have learned a lot as to in terms of the right time. Because the thing is, if you start the person on chemotherapy and you do a liquid biopsy later, well, the amount of shedding from the DNA from the tumor is going to go down significantly. So you're not going to get a good sample, and that's not going to be sensitive. So if you think of any test, even if you come up with, let's say, a screening test for HIV, as you know, some of these tests, their sensitivity, specificity is important depending on the prevalence of that particular disease in the population that's being tested. Liquid biopsy is also is an indirect assessment because you're hoping for the shedding in the DNA in the blood. So you have to do it in a time where you expect most DNA to be shed, which is right before treatment when you don't have any treatment to decrease the shed yet, or do it at the time when the cancer is getting worse. So liquid biopsies in general may not be the answer for all kinds of tumors, and I've done it in some of the other tumors that make our way to our clinic. Like, for example, there is a gastrointestinal stromal tumor, which is kind of like a sarcoma and doesn't have as much DNA shed as opposed to some of the other GI cancers. Also depends on what stage of the cancer are you testing. For some of these stage 4 cancers, you saw some of the examples I showed you.
Mhm.
They are very sensitive, and you're able to detect these clones. And we will be presenting and publishing some of our results as well to kind of truly show its value. Again, just like any other test. No one test is going to be an answer for, especially for all cancers. Some of these guidelines were kind of like for all cancers, but for colorectal cancer specifically, and a lot of the GI cancers, and we have this year at ASCO, we have uh, several abstracts where we've shown its value in cholangiocarcinoma patients. We've shown its value in liver cancer patients, and then for colorectal, I am compiling all the data because a lot of it is serial as well, so there's more data mining to do. But the results I've been getting are pretty accurate and impressive. And MD Anderson last year, they issued a press release where they have partnered actually with Guardant, where they've made the liquid biopsy as part of their standard of care. And to some extent, us here in Mayo, Florida, we have made that part of standard of our care as well, because, you know, um, you can do it non-invasively without actually getting a tissue. B, more importantly, you can do it serially over time, and then we're acting upon it as well, because, there's no point of getting a test if you're not going to change the person's treatment. So where we are able to get results where we're changing treatment, I think that's where we're in that right now. We're in that window of opportunity where we need to show its value, and the studies have to be designed well, and also needs to be focused in one disease than a group, rather than just saying, "Oh, this is not going to work for all cancers." Well, I think the same logic was for comprehensive tumor-based testing initially. They were like, right now you see all these naysayers where they're like, well, you don't have to comprehensively profile the tumors. It's a waste of money and stuff. But then, every year when I go to ASCO or some of these conferences, every year there's a new target for colorectal cancer patients. Initially it was the KRAS, and then they said it was NRAS, and then they showed that it was HRAS. And now we have BRAF as a target with some of these studies like Beacon. Then, HER2 now is a new target where it's a mechanism of resistance. Plus now we have treatments that are anti-HER2 based that are showing effectiveness. There was a new target that was just shown to work, something called NTRK or NTRK, which is present in all kinds of cancer. And this is the first time they published the results of a drug which targets NTRK, and it's present in patients with pediatric tumors to adult tumors, and it works in all, which is very impressive. And the only way you will know this is if you genetically profile these tumors. And
Right.
especially when you talk about young patients with colorectal cancer, which is one of our areas of main focus, those are patients where you really need to know as much information. At least I, as an oncologist, or if it were me as a patient, I would like to know as much information as possible about my tumor at baseline. And then also when the tumor stops responding to treatment, we should be thinking of all these things as potential tools in our toolbox to overcome this with as much information as possible.
So then, on the note of patient education and whatnot, we had a few questions come in surrounding that. One of them being, what are some good ways for patients to become educated about clinical trials that utilize liquid biopsies? And then, and then I'll separate those questions. So I'll start with that one.
So right now we have a huge effort that's ongoing right now. We call it Colomate, which is a liquid biopsy platform basket clinical trial that is opening up all its arms for different treatments for patients with colorectal cancer, and they will be screened based on liquid biopsy. So this is happening as we speak. Right now, one of the arms actually is already open, and it's taking patients who may have HER2 detected on liquid biopsy, and it's open in several places in the country. And actually, the trial also pays for patients to go to these sites if they are not residents of that city or state, because some of these, precision medicine-based trials are hard to find. So that arm is already open. So depending on the results of the liquid biopsy, you could get anti-HER2 treatment if your tumor has acquired HER2 over amplification or resistance mechanism. And then in a national effort with colleagues from MD Anderson, Duke, Mayo Clinic, Ohio State, and a bunch of other academic centers, we are right now in the process of seeking industry partners for each potential arm of a liquid biopsy-based clinical trial. So some of those, as we're getting approval, like for example, one of the arms will try to give anti-EGFR treatment again. The other arms will try to get more drugs for BRAF. I'm trying to focus more on the breast cancer gene causing colorectal cancer, and that's also increasingly being recognized. Breast cancer gene is mainly associated with the pancreas cancer, but we have seen an increasing number of patients who may have the colorectal cancer because of that, either in the tumor or in their blood. And as we know, for some of these cancers, there are new drugs which are called PARP inhibitors, which are targeted therapies that effectively overcome one of the weaknesses of these tumors, which is DNA repair, that led to these individuals developing tumor in the first place. So those trials um, are being developed, and some are open as we speak. Right now, the way to find these trials is the companies themselves are taking the effort of triaging the patients to which trial to go for. So I actually just recently saw a patient who had the liquid biopsy test done somewhere else in Florida, and I have a trial for BRAF mutant colorectal cancers open here in Mayo, Florida. The local oncologist as well as the patient was informed about the results of the liquid biopsy and the fact that there was a trial at Mayo, Florida for which the patient would be a candidate for. So we saw that patient, and the company helped in triaging the right trials for the patient. So more and more the patients or the patient advocates or navigators or even the oncologists, they actually now look at the location of residence of the patients, and they're able to geographically tell you what's the closest academic center where you can go for a trial. So that has been very helpful.
That's great. And then how, I guess we'll probably have time for one more question. Along the same lines, how are liquid biopsies used for patients who may be no evidence of disease but now show recurrence? Can it still be used in that setting?
So, um, ideally it's meant for kind of the situations we talked about, but there were several instances last year where we had instances of question of a lymph node being positive for cancer concerning for recurrence, but then it was in an area where we're surrounded by blood vessels where you couldn't get a biopsy. In those instances, we pursued a liquid biopsy to kind of see if we're able to detect the same mutations of interest, keeping in mind the caveats that I mentioned earlier. If we have the baseline tumor testing showing what mutational makeup of the patient's tumor was, and if the same mutations are now detectable, then you could use that information to identify recurrence early. Some of those are questions of trials that are ongoing right now. One of the implications that I already see that is being included in some of the trials is, for example, for rectal cancer, there is now a new wave of do all patients need surgery after they've had chemo and radiation? And I think in the future, what's going to happen is they'll do, let's say, a liquid biopsy at the end of somebody's treatment and see is there any detectable DNA? And if yes, then that person should go and have the surgery done. And if not, then maybe you could watch that person. So that is a question that is being answered in the trials. That are some that are already developed, and it's a matter of time before they show the results. I think they will show very promising results because they'll employ some of the methylated markers, which are more sensitive. But just like mentioned earlier, they answer a different question. They are more helpful to say recurrence, yes or no, as opposed to what specific mutation, yes or no.
Gotcha. Okay. Well, thank you. And then I guess I do have time for one more question. So correct me if I'm wrong, but uh, currently there are no FDA approved liquid biopsies specifically for colorectal cancer, even though Garden, I believe, just went through an expedited process. So for a patient that may be beginning treatment, what's your recommendation in terms of conversations they should have with their doctor? Since this isn't necessarily like a standard pattern of care, what do you recommend for patients that may have this option for bringing it up with their physician or oncologist?
You bring up a great point because that's, all the diagnoses and treatments, they have what we call the financial toxicity because a lot of these tests and treatments, they're expensive. And even, let alone liquid biopsies, comprehensive genomic profiling too is not necessarily approved for all cancers. Some of these approvals are undergoing FDA review and have recently gone FDA or Medicare approvals recently. But what's helpful is a lot of these industries, they work with the patient's insurance to kind of get whatever they can in terms of a reasonable copay, and then a lot of times they forego the cost of the test. So we have frank discussions with our patients as to what the actual cost of the test is, how these industries bill insurance companies. Most of them don't even bill Medicare or Medicaid, so in those patients, they don't even chase them per se. In others, they may bill the private insurance and they may call the patients ahead of time, so it's not like you end up with the bill later. So they usually call the patients ahead of time to kind of talk to them about what the copay is going to be, and if it's not something that's not reasonable, we tell our patients to not do the test in that instance. But for how long that is going to be sustainable, I don't know, because that's not a sustainable solution to kind of, it also takes a lot of time as well when we talk to our patients about how we're going to help arrange with the cost of the test and what if they ended up with a bill, how to help with financial assistance and applications and stuff. So, as we do more and more of these tests and genomic profiling and research and consents and trials, we only have so much time to really talk to the patient. So it would be nice for these tests to for studies to show its value so that they're approved, so that we don't even have to discuss any of the financial implications because it will be covered. Right now, just like you rightly pointed out, it's not approved yet, so especially for colorectal cancer patients. So in that setting, there was a meta-analysis that was just published not too long ago where 8 different studies specifically focusing on KRAS showed that different ways of detecting it, they were able to detect it with very good sensitivity and specificity. So it's just a matter of time before somebody is able to do a good study and show its true value, at least for patients with colorectal cancer. And that's one of the areas of research that I'm focusing on in terms of showing its value so we can, bring it to prime time, so to speak.
Well, that's great to know, and I think you've brought up some amazing points, and even things that I didn't know in terms of that ASCO and CAP review, which I will be looking at more closely. But I believe that is all the time we have for questions. Thank you so much, Dr. Kasi. This was super, super informative. And I know, kind of like you said, this is a hot topic. We're looking at how this is going to be ready for prime time for colorectal cancer patients. And we really do appreciate you jumping on the call today. If any other questions come up, feel free to email me and I will send them along to Dr. Kasi. And with that being said, thank you all for joining and have a good rest of your day.
Well, thank you again for the opportunity.
Thank you so much.